Hello, everyone, and thank you for joining us. I'm Kate Fahrenholt, the Executive Director of NAMI Maryland, and I'm joined by board member Cherie Strong, who will be our moderator for today's webinar. September is Suicide Prevention Month, and suicide prevention is a leading priority of NAMI Maryland. Infectious disease outbreaks such as COVID19, as well as other public health events, can cause emotional distress and trauma, confusion, anxiety, and isolation. Unfortunately, there has been an increase in suicide ideation and behavior among at-risk populations. Today, we're hosting Lieutenant Governor Boyd Rutherford, who will highlight the importance of suicide prevention, as well as discuss some of the state's efforts in addressing the suicide epidemic. We are also joined by renowned experts, Dr. Holly Wilcox and Dr. Paul Nestadt, who will help us learn the basics of suicide risk and prevention during COVID-19, identification and early warning signs, and new protections to mitigate suicide in at-risk populations, such as Maryland's Extreme Risk Protective Orders, ERPO law. Cherise?
Thank you, Kate. Before we get started, we wanted to note just a few housekeeping points. To avoid background noise, all participants will be muted for the duration of the webinar. We will be addressing questions at the end of the webinar. If you have any questions as the webinar continues, please enter them into the questions box, which is located on the right-hand side of your screen if viewing from a computer, or at the bottom of your screen if viewing from a phone. If you have any comments or concerns during the webinar, please also enter these into the question box. We will review them and address any immediate needs as they occur. A recording of this webinar will be emailed to each registrant tomorrow. The recording will also be available on our website at www.namimaryland.org for any individuals that are unable to register. CEUs are not provided for today's webinar, but a certificate of attendance will be sent to each registered participant tomorrow afternoon. After the webinar today, you will be asked to complete a short survey on the aspects of this webinar that you felt were helpful, could be improved, and what you would like to see in future webinars. We plan to continue hosting educational webinars, and we ask that you please fill out this survey to let us know how NAMI Maryland can best support you during this time of need.
Thank you, Cherise. NAMI Maryland is proud to support the work of Lieutenant Governor Rutherford and Governor Hogan's administration on spotlighting mental health in this state. Lieutenant Governor Rutherford has chaired the Commission to Study Mental and Behavioral Health in Maryland since it was established in 2019. His commission has been tasked with studying mental health in Maryland, including access to mental health services and the link between mental health issues and substance use disorders. Through his leadership, numerous stakeholders have been able to collaborate and offer recommendations for policy changes to promote mental health care and access. As members of NAMI Maryland, we understand that mental health care is not just about access. NAMI advocates for individuals receiving the proper care in the proper setting, while also working to ensure that proper follow-ups in the care process occur. We believe that Lieutenant Governor Rutherford shares our understanding that mental health needs to be addressed on multiple fronts to truly see better outcomes. NAMI Maryland is a proud ongoing outreach and education partner for the Governor's Commission on Suicide Prevention, and I'd like to now welcome Lieutenant Governor Boyd Rutherford, who will discuss ongoing suicide prevention efforts in Maryland. Lieutenant Governor.
Thank you, Kate, and good afternoon to everyone. It is a pleasure to join you virtually for today's webinar on suicide prevention during this COVID-19 pandemic, hosted by NAMI and Maryland chapter, and I appreciate this opportunity to talk to you. As we know, and Kate just mentioned, COVID-19, the pandemic, has changed our daily lives and has led to increased uncertainty for individuals and families as well. Not only did we grapple with the loss of loved ones and loss of jobs and opportunities, but there was a profound loss of connection to people and places and activities that make us feel whole and grounded, happy, healthy, and safe. You know, this month, and I think Kate just mentioned, is Suicide Prevention or Awareness Month. And the issue of suicide is something that's prevalent, persistent, and one we cannot afford to ignore. The Centers for Disease Control and Prevention reported that more than 47,000 people died by suicide in 2019 across the country. More than 650 of those deaths were reported here in Maryland. Suicide is and I know you all know this, but it's the second leading cause of death among individuals between the ages of 10 and 34, and touches everyone regardless of their race, gender, or economic background. There's no single cause of why someone takes their own life, but we know that the majority of those who do die by suicide have a diagnosable and treatable mental health condition that is often not recognized or treated in time. We are trying to take a thoughtful and collaborative approach to addressing this issue and taking every opportunity we can to enhance the delivery of mental health services and support in Maryland for all those who may be considering suicide as well as their loved ones. Our suicide prevention program, working through the Governor's Commission on Suicide Prevention, along with state and local agencies and community organizations and providers, is aiming to increase awareness on suicide and identify at-risk individuals. The program also provides resources and support and interventions that promote healing and improve the quality of life. One of the key resources available is by phone as well as online is Maryland 211, which connects Marylanders with essential services, including mental health support. Someone having a crisis, mental health crisis, can connect with Maryland's crisis hotline by dialing 211 and pressing 1, or the National Suicide Prevention Lifeline, available at 800-273-TALK. And that helps, with those helplines, are tools to help de-escalate a situation over the phone and dispatch mobile crisis personnel that can help in that time of crisis. During the pandemic, the Maryland Department of Health also launched MD Mind Health to encourage mental awareness and mental wellness. If someone sends a text to 898-211, they receive supportive messages related to the way to improve their mental health, and remind them that mental health and services are available to them wherever they live. Operation Roll Call is a program that offers regular check-ins for our veterans, our Maryland veterans, as well as a chance for them to talk to someone who can offer support. Kate mentioned that I chair the Commission to Study Mental and Behavioral Health, and to discuss interventions and prevention strategies related to the factors that put someone at risk of suicide, including those with substance use disorder. I'm proud that, to be able to work with organizations, closely with organizations from the Maryland chapter of NAMI, as well as the American Foundation for Suicide Prevention, to raise awareness of these issues and make sure resources available to those in need. You all do this every day to make sure that where there is someone that is struggling with mental health issue or having thoughts of suicide, that we all are reminding them that they are valued and that they are not alone. There are people who care and resources that can be available to help them, and we always encourage individuals to reach out, the individual themselves, of course, their families, if they have any concerns. And preserving mental health and addressing mental health disorders should be a priority for all of us year round, and not just in a pandemic year. We often say, at least around here, that the tail of the pandemic is going to be, the mental health impact that it has had on so many individuals over this last 18 months. And it's going to continue even as we get past the pandemic, we recover from the pandemic. It's going to be a much longer time for many individuals who have, felt that isolation and anxiety over the last 18 months. And as you know, as well as I do, and better than I do, is that this has been a challenge for many years. And as I have said many times in our commission meetings, we as a country, as a state, as communities, have not done a very good job in helping those individuals and their families who are suffering from mental health challenges. And that is one thing that I have been, adamant in trying to do over these last several years. And it actually started before coming into office. And so, I thank you for this opportunity. I look forward to continuing to work with you, that we can continue to do, increasing awareness and decrease barriers to life-saving resources that can make a difference in people's lives. So, Kate, again, thank you. Thanks to everyone at NAMI for giving me a chance just to address you. And thank you for what you do every day and keeping people aware that this is a challenge, because, and I don't want to go too far because then too long, you give a person who's a politician an opportunity to talk and they don't know when to stop. But I just want to say for way too long, questions of mental health have been something that no one seemed to want to talk about. Families would, kind of not talk about that in polite company. They didn't want to talk about their child that may be having challenges, or their uncle who has challenges, or sister or brother. And so it's not their fault, and they're not alone. So thank you for what you do each and every day. And thank you for this opportunity.
Thank you, Lieutenant Governor Boyd Rutherford, for joining us today and for all that you are doing to improve the mental health, behavioral health environment in Maryland. Thank you.
Thank you. And I'm going to let you all continue with your program. Take care.
Thank you. You too. So I'd now like to introduce our speakers for today's webinar. And first is I would like to introduce Dr. Holly Wilcox, and I'd also like to introduce Dr. Paul Nestadt. So starting with Dr. Holly Wilcox, she's a professor in the Department of Mental Health at the Johns Hopkins Bloomberg School of Public Health, with joint appointments in the Department of Health Policy and Management, as well as the Johns Hopkins Schools of Medicine and Education. Much of her work involves population-based research on suicide, intergenerational studies of suicide, the evaluation of impact of community-based universal prevention programs, and data linkage strategies to inform suicide prevention work groups at Johns Hopkins. She has a diverse publication history that demonstrates her experience in biological, psychological, and social factors in suicide. And Holly was appointed by Governor Hogan to the Maryland School Board. She also co-chairs the Maryland Commission on Suicide Prevention. Thank you. And Holly has twice received the Johns Hopkins Bloomberg School of Public Health's Excellence in Advising, Mentoring, Teaching, and Research Advising, the AMTRA, I hope I got that right, AMTRA Award. Second but not least is Dr. Paul Nestadt, who is an assistant professor jointly appointed in the Department of Psychiatry and Behavioral Science at the Johns Hopkins Schools of Medicine and Public Health. He serves as the co-director and the supervising psychiatrist for the Johns Hopkins Anxiety Disorders Clinic, where he utilizes behavioral therapies such as cognitive behavioral therapy, CBT, and exposure, as well as psychopharmacology for anxiety disorders, including PTSD, OCD, panic, and generalized anxiety in patients from the United States as well as internationally. He's also founded and attends The esketamine clinic, and for more information on that, we will be probably having some information going out about that in the future. And he is an inpatient attending on the dual diagnosis motivated behaviors unit at Johns Hopkins Hospital. Dr. Nestadt's current research focus is on practical risk factors for suicide, and he's currently the course co-director for the doctoral level Suicide as a Public Health Problem. Dr. Nestadt is a leader in education regarding suicidality, anxiety disorders, and psychiatric evaluation at Johns Hopkins, where he regularly presents didactics and clinical supervision for medical students, residents, and doctoral students studying the epidemiology of mental illness. He's a fellow of the American Psychiatric Association and is on the executive board of the Maryland Psychiatric Society. He's written several chapters for leading psychiatric and medical textbooks, over 50 peer-reviewed papers, and is the managing editor of the Johns Hopkins POCIT Psychiatry Guide app. He has spoken nationally and internationally on the topics of suicide risk and the role of firearms, opiates, and the limitations of screening. We have two of the world's experts on suicide and suicide prevention. So thank you for both joining us today. I'm going to hand it over. And I believe we are starting with Dr. Wilcox, is that correct?
No, we're starting with Paul.
I apologize. So starting with Paul Nestadt, and I'm going to turn my speaker off so our speakers can present their fantastic presentation.
Thanks so much. Thanks, Kate. And I sent a very long bio, sorry. I wanted to make sure everyone can see my screen. Can everybody see the slides, or is it presenter view? What do you see? Is it working for you? Okay. So thanks for having me here today, everybody. It's a pleasure to speak to NAMI. I rely so much on NAMI, especially when I have patients that need extra support and their families need extra support. I think maybe it's my #1 referral that I make in all the various clinical settings I work in, is to look into what NAMI has offering for a particular issue for a patient. So today I'm going to talk about suicide, and specifically about firearm access and about the pandemic and how those three things kind of are interacting right now, unfortunately. As the Lieutenant Governor pointed out, suicide is a leading cause of death in the US. It's the 10th leading cause of death overall. And as he mentioned, it's the 2nd leading cause of death for Americans under 40. This is a very serious issue. The mortality rates for suicide, for young people especially, are really higher than almost anything else. And those rates have been rising. So this is a figure just looking at the suicide rates over the past 70 years or so. The second half of the 20th century here is compacted. So you can see that rates were pretty high after World War II, and stayed pretty high until around 1987, which is maybe coincidentally or maybe not, when Prozac came out, and suicide rates started to go down until the year 2000, and since then they've been slowly climbing, maybe about 33% over the past 20 years. Although happily, the rates went down a little bit in 2019. There was about a 2 or 3% decrease in the suicide rates in 2019, and we don't have 2020 data yet, but 2020 will be maybe an unusual year because of everything going on with the pandemic. Some quick epidemiology of suicide. Just to point out, this is the top left figure here is suicide rates by sex, male and female. The male suicide rate is much higher than the female suicide rate in general in the US and in most countries. In fact, almost 80% of all suicides are male. There's also differences in race and ethnicity for suicide. So white Americans and Native Americans both have very high rates of suicide. Their suicide is still a problem in other races and ethnicities, but the rates are much higher in those populations, have been traditionally at least. On the top right is a breakdown by age group, and Dr. Wilcox is going to go into a little more detail on different age groups, especially youth suicide. But just to point out, the solid line here is the general population suicide rate at each age. So you see there's sort of a highest suicide rate around age 50. There's also an increase in the suicide rate in the very old. So the over 85 population is not shown here. But when you break it down by race, there's interesting differences. The solid line is driven by the white suicide rate because it's such a high suicide rate among whites, but among American Indian, Alaska Native, there's actually a higher suicide rate in youth. Age 20 is really a peak. And to a lesser degree, that's also the case with Black Americans and Hispanic Americans, Latinx Americans, also slightly higher in young ages than suicide rates do vary by state. So in Maryland, we're relatively fortunate to have a somewhat low suicide rate compared to the rest of the country. This map just has darker shading for higher suicide rates. So as you can see, there's almost sort of a suicide belt in some of these more rural states, or Idaho, Montana, Wyoming. These have a higher suicide rate in general. You know, as we'll talk about today, some of that might have to do with higher firearm ownership in those rural areas. The same holds true in Maryland. The more rural states, Wicomico County, rural county, the Wicomico, those tend to have higher suicide rates than the more urban or suburban counties. All right, so suicide is complicated. It's a behavior. It's a choice that emerges ultimately from a variety of environmental and personal factors. Some of these are chronic risk factors, some acute. Importantly, some are fixed factors we can't do anything about, and some are modifiable. So some important fixed factors, immutable factors, having a family history of suicide is a risk, male sex and white race, as I mentioned just epidemiologically, having a terminal illness. These are examples of suicide risk factors that we can't change. Those something we can't intervene on. But there are other important factors we can address. So social isolation, poverty, experiencing homelessness, these are all risk factors for suicide that we can do something about as a society, as clinicians, as family. Access to legal means is the topic of this talk. We'll talk more about it in a minute, just to say that it's a modifiable risk factor for suicide risk. And then of course, mental illness, because this is the National Alliance of Mental Illness, I really want to highlight that as Lieutenant Governor Boyd Rutherford pointed out, psychiatric illness is one of the most significant modifiable risk factors. People with a psychiatric illness have a much higher risk of suicide, and we can do something about that. So with the numbers to that, most, 80 or 90% of suicide decedents do suffer from mental illness, either as a predisposing or precipitating factor for the suicide. This comes from psychological autopsy studies that have gone back and looked in depth at suicide decedents in their recent history. Psychiatric illness increases the likelihood of suicide by death by suicide a great deal. One way to think about that is that I mentioned the annual suicide rate right now at about 14 per 100,000 per year, which adds up to about a lifetime chance of suicide of 1%. So 1% of Americans are likely to die of suicide. For people that have a mood or anxiety disorder, that number quintuples. So the lifetime suicide risk with a mood or anxiety disorder is about 5%. With schizophrenia, which is a less common disorder than mood or anxiety disorders, the rate increases even more. 10% of people suffering from schizophrenia will die by suicide. Substance dependence is a little bit more complicated because there's lots of comorbidities. So in general, people with substance dependence disorders, substance use disorders, have 8 to 15% the risk of suicide, which is high. Part of that has to do with a lot of comorbidity. People that have substance use disorders are more likely to have mood disorders and psychotic disorders. And so that adds together. But it's important to recognize psychiatric disorder as a risk factor because psychiatric disorders are treatable. We can do something about them. Now, I've been talking about suicide deaths, 48,000 suicide deaths in the US each year. But it's important to recognize that there are many more attempts than there are deaths. There's about 1.5 million suicide attempts among adults annually in the US. Of that, about 500,000 adults are admitted to the hospital for the attempt, which might be a proxy for the severity of the attempt or lethality of the attempt, requiring hospitalization, medical treatment. And yet only about 48,000 die by suicide. So this is a lot of people dying by suicide, but thankfully it's a small proportion of the people that are attempting suicide. So with all the attempts, the question arises, how do so many people survive their attempts? Well, some of our first clues come from looking at sex differences, at epidemiologic demographic differences in people who attempt and people who do die by suicide. Notably, females have 3 times the suicide attempt rate compared to men, and yet men have 3 or 4 times the suicide death rate of women. Why is this? I think that a good explanation, although maybe not the whole explanation, maybe a large part of it, is that suicide attempts have a relatively low fatality rate. So this table on the right here is from a study that's actually a replication of an older study, all basically lead to the same sort of numbers. In this study of almost 4 million suicide attempts in the US, the team found that only 8% of them were fatal, and there were significant differences in the method used and the case fatality rate. So the most common suicide attempt method by far is poisoning, is overdosing, Tylenol or opiates, any number of poisons, or drugs or medicines, made up more than half of all the suicide attempts in the country, which is the CDC data. And yet, fortunately, they resulted in only 43,000 or 44,000 deaths, meaning that the case fatality rate, the chance of dying in a poisoning attempt, is about 2%. So 98% of people do survive and get treatment and do well. But compared to firearms, we get a very different story. So relatively very few attempts are performed by firearm. In this study, 175,000 out of, as I said, almost 4 million. But those didn't account for most suicide deaths. In this study, 157,000. Because firearms have a very high fatality rate. A firearm suicide attempt has about a 90% fatality rate. These are very lethal weapons. So if a firearm is what's used in the attempt, it's usually fatal. And men tend to use guns, whereas women who are more likely to overdose use other methods that might not be nearly as lethal. To put this into a context here, I mentioned there's a lot of complication in looking at risk factors for suicide. So this is a diagram by Keith Houghton, a British suicidologist, that is one way of looking at suicide risk. Lots of factors go in to ultimately risk for suicide. Genetic factors, personality factors, I mentioned psychiatric illness, disorders. Distress obviously plays a huge role, chronic pain, exposure to suicide culturally and seeing or being around suicide and self-harm. But ultimately, these all lead to one sort of bottleneck, one decision point. An attempt is made, and that attempt either results in a death or in an attempt which is survived. And really, the only thing that distinguishes suicide death from survived attempts is whether the method is likely to be lethal. So when that attempt is made, if it's made with a firearm, there's a 90% chance of this being a death, whereas other methods have much lower risk. Now, even though only 5 or 6% of suicide attempts in the US are made by gun, firearm suicides account for more than half, about half, a little more than half of all suicide deaths in this country because of that lethality. There's been lots of studies that look at the specifics of the increased risk of suicide for people that have access to a firearm. The bottom line is that it provides a means that becomes really one of the most significant risk factors for suicide death. We know that states, areas, and household studies that look at each of these individually, areas with more gun ownership have more suicide deaths, actually especially in children, where areas with high gun ownership have double the suicide death in general, triple the firearm suicide rate. Individuals with access to a firearm on an individual level have triple the risk of suicide, controlling for every other factor, mental illness and everything else. And we know that policies which limit gun access or support safe storage are strongly associated with reduced suicide rates. And I won't go into all of these different studies, but it has been consistent in the literature that just about every type of lethal means access policy, whether it's requiring background checks or waiting periods or requiring guns to be stored safely, all reduce suicide rates, firearm suicide rates and total suicide rates because they're so driven. To understand why that is, it might be useful to think about suicide as often an impulsive act. Now, not every suicide attempt is the same. There's lots of pathways to suicide, and everyone is different. However, as epidemiologists, we have to look at the bulk of what's happening, sort of the driving forces in the majority of cases to address the lowest hanging fruit, to prevent the most deaths. And so we look at studies like this, where they interviewed 150 people who had made really high likelihood of lethality suicide attempts. And they interviewed them after the attempt. So how this might have gone would be the researchers would talk, this was in this particular study, young people, talk to these young people who had made serious suicide attempts and ask them about the decision process. When it was something like, I know that you've been depressed for a while. I know you might have been thinking about suicide for a while now. But how long passed between the decision that you're going to end your life and then acting, the sort of decision to action? And the study found that 87% of them, so almost 90% of them, had only decided to make the attempt within 24 hours of the attempt. Most had decided within the hour. In fact, if you look at this figure, a quarter of them, it had been less than 5 minutes, half of them less than 20 minutes. And as I said, 70% within an hour. And what that tells you is that people will use what they have. If it's got this impulsive component, then you use what's around. If it's 2 in the morning, which is unfortunately a common time for this decision to be made, and what you have available is what's in the bedside table, if it's a bottle of Tylenol, it's likely that the attempt will be survived and treatment can be sought. But if it's a firearm in the bedside table, then the chance of death is much, much higher and help not be done. Now, COVID-19 has upended everything, obviously. As the Lieutenant Governor alluded to, it has been, well, it's an understatement to say, a difficult time for a lot of people. It started spreading globally in 2020, bringing illness, bringing death, as well as lockdowns, economic and job losses, isolation, grief, both grief for lost loved ones and for a way of life, and reduced access to care and supports. I can tell you that on the inpatient unit where I was working in the spring, when COVID really kind of first hit Maryland in March, April, and May, the people coming into the hospital, the patients I was treating were people who had been relatively stable in the community with high supports like IOP support and group homes that couldn't provide that during COVID, or AA and NA and NAMI, where it was harder to meet in person and people tried to pivot to Zoom. These supports disappeared and they ended up hospital. Now, because of that and other things, suicidologists predicted a mental health crisis. In fact, there was a really good paper that came out of Tom Joyner's group that suggested that the pandemic created a perfect storm for increased suicide rates because of the economic losses, the stress, isolation, increased access to support, including community, religious, and mental health care support, and firearm sales. And the pandemic's a little bit unprecedented, but we do know that similar sorts of things have had impacts on suicide. We noted that suicides increased during the 1918 and 1889 influenza epidemics, although data wasn't great back then. We know that in 2003, when Hong Kong went through the SARS crisis, SARS-1, elderly suicides in particular increased by 30%, even higher in elderly women. So the subpopulation of particular risk, in this case, maybe of loneliness during the isolation period. And importantly and relevant for this talk, I mentioned firearm sales really increased during 2020. So in March, when the pandemic was first happening, the New York Times had a headline story, a cover story on the firearm increase. They said that March 2020 had the second highest number of new firearm purchases since data had been reported, the second highest ever. The first highest was, I think, right after Obama's re-election. There was an increase in gun buys. But this was a 41% increase in March 2020 compared to March 2019. That made headlines. But then as the media stopped following it, the numbers kept going up. June then broke that record, became the highest by far month for firearm sales. And then July, August, October, November, December all had 50% increases over the equivalent months in 2019. And then in January 2021, we actually crossed 4 million sales in 1 month. And then by March 2021, there were 4.7 million sales. These were doubling the rates we used to see in other years. And importantly, 40 to 67%, depending on how you measure it, of these purchases were to new gun owners. Now, this is an important nuance because historically, sales spikes, when there's been increases in gun sales, as measured by background checks for new sales, have been from policy change. As I mentioned, when Obama was reelected, there was a large spike in gun sales. And part of this comes from people who are already gun owners, but become worried because of new policies that it'll become harder to get guns and sort of more barriers to them acquiring more guns. So they're existing gun owners who buy more guns. The figure on the right here is looking at over the past 20 years, the background checks per 1,000. So basically the rate of people buying new guns. And it divides it into blue Democratic states and red Republican states. As you can see, throughout, really history of reporting data, there tends to be more guns bought in red states, which won't surprise you. There's more hunting, there's sort of states that are more likely to buy guns. And the spikes that happen, like I said, in election years or policy change years, or like when there's a big shooting, tend to be spikes really driven by red states. You see this spike here in 2015 and 16. But this spike in 2020 was different. For the first time, it was a spike, a major spike, the biggest spike, driven by blue states. There was an increase in red states, but really it was the blue states. And these tend to be new gun owners. These aren't people that already own guns. And new gun owners are more worrisome because they might not be trained in proper firearm safety, storage, the use of firearms. This was a survey that Lions did in 2020, surveying pandemic purchasers, so people who were new gun owners that had bought a gun during the pandemic. Lions found that half of them had never had any firearm safety training of any kind, found that 42% reported at least one of the guns that they bought was stored unlocked and available. More than half reported there were kids in the house. So that's a lot of kids having access to unlocked guns. And I'll point out, for those of you who don't remember, 2020 also meant that kids in the house meant kids really in the house. They weren't at school. They were running around in the house, theoretically on Zoom school. I know my kids, I got a 5 and an 8-year-old, so Zoom school really meant running around in the house. And now there's an unlocked gun in the house. 33% of people surveyed had a household member with a mood disorder. 11% had a household member with dementia. This is a major issue that I'll often give talks on, specifically dementia, gun ownership, mental illness. It's a dangerous combination, dementia and gun ownership. 15% have been laid off in the pandemic, and almost 40% reported that their mental health had gotten a little or a lot worse in just the past month. So I want to cut to the chase. It's important for us all as members of the mental health care community and people who are members of the psychiatric community and patients and families and caregivers and community supporters that during a health crisis, a mental health crisis in the household, it is incredibly important to remove the weapon from the house if possible. In at-risk periods, guns have to be removed, pills locked up, there's other lethal means. And depending on risk assessment, the patient might need to be taken to an emergency room. Families play a huge role in enacting all of these plans, including holding and locking away weapons and medications. And there's a couple different ways to do that. This is a good figure from a Megan Ranney paper from about 5 years ago. Many of you might know Megan Ranney now because she's on CNN all the time talking about masks, but she started her career in public health looking at guns and suicide as an ER doctor. This lists a few different ways you can store a gun safely that can be gone over with family members, patients, gun owners, ranging from cable locks up here. The cost here is listed at $10 to $50. In reality, they're cheaper. I mean, you can get free cable locks from the police in most counties through Project Child Safe, through the VA will give out cable locks. In fact, when you buy a new gun, they generally come with a cable lock. You go outside of a gun store, you'll often see a bunch of cable locks sort of in the trash. But these are a good sort of maybe thin barrier, but it's something preventing gun access that can be cut. Trigger locks are a little more expensive, maybe a little more effective. Lock boxes are fantastic if your family member can afford them, because you can also keep lethal medications in those, but they're not being used. And safes, disentangling the gun, smart guns, a whole other conversation. And importantly, you can transfer possession. So depending on the state, and here in Maryland, it's a little complicated. We can talk about it if you have questions about it, but essentially you can do an emergency transfer. A family member or a friend can hold on to the gun temporarily. There's some downsides to this. That person hasn't had a firearm background check, and the law is a little bit gray about that. And also, you put the onus on that family member to decide, when do I give this gun back to the person at risk? You know, you're asking them to do a risk assessment, which is difficult. You can store guns with law enforcement, and you can store guns at gun stores or shooting ranges. In fact, Maryland is one of the 4 states which is fortunate enough to have a safe storage map that was put together by Casper Fossey's team at Hopkins Bloomberg. The URL is there, mdpgv.org/safe storage map. See it there. You go there, you can search your area and see gun stores or ranges that have agreed to be willing to temporarily store guns for you or your family member until the crisis passes. And then there's the red flag laws. So this is a relatively new tool here in Maryland. Red flag laws are the laws that allow police or family members to petition a court to temporarily remove firearms from people who might be a risk themselves or others. This is not about mental illness specifically, but any number of reasons that someone might be a risk. Connecticut passed the first one of these. They called it a risk warrant back in '99 after the school shooting. And other states did follow with a huge increase after Parkland. So, you know, the Parkland shooting impacted state policies on guns across the country. And now we have 19 states in DC that have some version of a red flag law. 2018, after the Parkland shooting, also included Maryland. Maryland passed ours that went into effect in October of 2018, so it's pretty new. If you haven't heard of it, it's new. Our version is called the Extreme Risk Protective Order, the ERPO law. And it was the first state law, red flag law, that included physicians and other clinicians as petitioners. That includes social workers, psychiatric nurses, psychologists, and doctors as potential petitioners, people that can file these petitions. Now, we've looked at these ERPO laws, these red flag laws, to see if they're effective in it, and they are. So Jeff Swanson down at Duke did a really elegant study looking at Connecticut's version of the law. Remember, Connecticut had been around the longest. The study was done before the wave of new red flag laws after Parkland, and found that Connecticut's version of the law saved 1 life for every 10 or 11 guns that were seized, 10.6 guns. In the medical community, we call that a number needed to treat. How many of these do you need to file to save 1 life? For every 11 filed, a life was saved, which is a reasonable trade-off. Remember, this is taking away someone's right to own their gun temporarily. So you want to make sure that it's saving lives if you're going to be doing that, and it is. Aaron Cavisto and Peter Fallon, Peter's now at the VA here in Baltimore, but when they were in Indiana, used a synthetic control model, sort of a complicated analysis, to look at Indiana's version of the law, and found that it reduced firearm suicides by 7.5% over 10 years, without any increase in suicides by any other means. So the firearm suicides went down. And now these are mostly designed, well, they mostly impact suicides because 2/3 almost, 63% of all firearm deaths are suicide. But these laws really came out of mass shootings. And so Garen Wintemuth's team in California have looked at these laws and found they've also prevented a lot of mass shootings. This study that I mentioned here, Garen looked at the most recent 159 ERPO records in California. They call it the gun violence prevention order, but red flag records over the last 2 years in California, and found 21 times when a mass shooting was clearly stopped. An example of that would be something like we had in Pasadena, Maryland. You might remember that when the ERPO law here was less than a year old, in September of 2019, there was an ERPO that was recommended by some coworkers of someone. The respondent, was considering shooting up his workplace, and his coworkers suspected he might be. So called the police, filed an ERPO, and the police went and found almost 150 guns in the man's home, and some paperwork and plans that he really was going to shoot up his workplace. So that was a mass shooting that was aborted thanks to this law. I mentioned Maryland's the first state to allow clinicians to file these orders, although DC and Hawaii now allow clinicians as well, and Connecticut is about to follow. It's about to have clinician filing as well. But it's still a lot to work out as far as clinician filing, and I think it's important as family members, people with mental illness, as people suffering from mental illness, and as people that work with the psychiatric legal community, how these ERPOs work. So let's talk about them a little bit. This is specific to our state. So in Maryland, the ERPO can be filed by family, roommates, cohabitants, romantic partners, police, or clinicians. And as I said, clinician includes physicians, psychologists, mental health workers, psych nurse, social worker. Emergency petitions, which sort of will result in someone being emergency evaluated by a psychiatrist, can be filed at the same time, but don't have to be. The bar for ERPO is lower than for emergency petitions. So it's written as the respondent, the person with the gun, must pose an immediate and present danger to themselves or others by being armed. There's no requirement for a mental health diagnosis. It's really about the danger. So those of you who are familiar with emergency petitions, know that's a difference between EP laws. The order results in police removing any guns the person owns. So when you're filing, if you're writing up an ERPO for the police or for a judge, there's a section there where you write where you think they might have guns. The police will search, but if you happen to know, oh, there's one in the bedside drawer or something like that, that's very helpful. And it prevents the purchase of any new guns. This is important. So someone can't just have their guns taken away and then go right to Walmart and get a new gun that day. When they're under this temporary restraining order, their ability to purchase guns is stopped. When you file them as a family member or a clinician, the judge orders a temporary order without the respondent present. So it happened, you don't need the respondent to be there in court. It's just a temporary order though, and within that takes the guns away. But a final hearing is held within a week, within 7 days, with the respondent present, at which the order can be more formally evaluated as the emergency period passes. It can be extended up to a year, and later with more hearings can be extended a further 6 months, so a maximum of 18 months of temporarily not having gun access. It's not a permanent measure. No one's losing their right to own a gun permanently. It's just during a crisis. So some points that are worth discussing. These can be filed against guardians of a child in crisis. So if you have a child, a young patient or a nephew or a child that is having a mental health crisis, they're not the gun owner, necessarily. In Maryland, you can't possess a handgun or now a long gun, thanks to a new law, if you're a child. But it can be filed against adults who have a gun in the house. So if dad has a gun and is sort of refusing to separate the gun from the household where the child lives, they can be filed in those situations. So of course, you would always talk to the family first. 9 times out of 10, just having a conversation. Look, your kid's in a crisis right now. I know that that it's important to have this gun for your protection, or that it's hunting season, you want to be going out and hunting. But just for now, can we just can you store it at the shooting range? Can you store it with your brother-in-law? Whatever, just right now. But it's really if in extreme situations, that's why it's the extreme risk protection order, that you can then sort of take this measure. Illegal guns that are taken in the serving of an ERPO won't be returned. So the person who owns the illegal gun won't be arrested. This is an important thing. It's always a risk sending the police into someone's house. And especially someone you care about, you don't want them to go to jail, which is itself a suicide risk factor. People won't be arrested, but any illegal guns that are turned up won't be returned. A petitioner, the person filing the ERPO, can't be sued for filing. You can't have somebody come after you and say, you took away my rights without due reason. You're sort of good Samaritan lawed into that being allowed. The way that Maryland's law is written is ambiguous, and you actually can be sued for not filing if there's someone at risk. So this hasn't been tested in Maryland, but in Indiana, for instance, there was a family who sued another family successfully because they had failed to use this sort of a law to take away the gun of a family member who then shot someone in the other family. So basically there was a shooting, and the victim's family then sued the family of the person who did the shooting because they did not file an ERPO. Now the ERPO avoids the problem with having family take away the guns, which, as I said, is a legal gray area in a lot of states, including Maryland, because we're a background check state. So just giving your gun to someone is technically legal. There are case law, not actual legislation, that allow for temporary emergency transfer like this, but it's vague. How long can it be for? What is the sort of criteria for giving the gun back? What happens if a crime is committed with that gun while someone's holding it? This is a little bit cleaner than that. And so for that reason, it's often the preferred method we recommend for family members who are concerned about someone with a gun. And often it can be done with their cooperation. The person that owns the gun that's in crisis might say, yeah, you're right. This is not a good time for me to have the gun. I feel weird about giving it to the shooting range. You even have people that have ERPO'd themselves for this reason. And just to sort of start finishing off here, it's important to recognize that these ERPOs are being filed. In Maryland, we are filing lots. This is the rate per state that comes from Sheriff Hopkins' office. He's a Montgomery County sheriff who's been tracking these. In Baltimore, we don't do very many, but in the more rural counties, there's a lot. We filed 1,700 in the first 2 years in Maryland. Comparatively, California, which is much bigger than Maryland, only filed 200 in the first year. And clinicians tend to not be filing these, which is a topic we can talk more about. So just in summary, suicide is the leading cause of death. The rates are rising, and it's preventable. The pandemic might exacerbate anxiety and stress and provoke known suicide risk factors. And because suicide is an impulsive act in many cases, people use what they have. If attempters live, they have a chance to get help. But if what they have is lethal and very accessible, they're likely to die in the attempt. So screening for firearm access, regulating access to firearms, requiring safe storage, and generally decreasing firearm prevalence will likely save lives. And ERPO is one method of doing that. So thanks. So I want to hand this over to Dr. Wilcox, but we'll have time for questions at the end. Let's see if I can stop sharing my screen. All right. Thanks, everybody.
Hopefully you can see me and you can see my screen.
We're all set to go, Holly.
Perfect, thank you. So hello, everyone. I'm really excited to be here. I'd like to first start by thanking NAMI for being such a key partner in suicide prevention and just a key resource in the state. I also want to thank folks in our suicide prevention office in the state of Maryland. They do a really fantastic job. And through the pandemic have been working really diligently and really hard. And we have our suicide prevention conference coming up soon. And so Indu, Natalie, Sierra, and Alex, just wanted to give a shout out to them and thank them for their work on this front. There we go. So I just wanted to talk about some of the big challenges that we have been facing in the field of suicide prevention in general that have become even more salient during the COVID-19 pandemic. Just in terms of the field, for the most part, the field really focuses on the people who are already at risk and already suicidal. So here you see in this really simple figure that there are those folks that are kind of in the more severe area, already experiencing a lot of distress and suicidal thoughts and behaviors. And the field largely allocates resources to the individuals who fall in that high risk category. But really what we need to do is to also think about taking more of a population-based approach. And so thinking about taking the population's risk and shifting it to a lower state or lower category of risk. And different types of programs, evidence-based practices, and policies that really can do that, shift everyone's risk and lower it. And ideally, what we would want to be able to do is prevent people from ever becoming suicidal, and try to think of strategies and approaches that can get us there. The epidemiology of suicide, as Paul was mentioning earlier, has really been shifting over time. One thing that I focus on specifically is trying to get upstream and thinking about a certain skill set that can be given to young people as young as possible prior to them becoming at risk, that could give them a skill set, problem solving skills, coping, that could potentially help them navigate their own suicidal crisis or that of a family member or friend or another loved one. And so thinking about approaches that can be embedded into school and other settings. And I think this is important, as you see from this figure that Paul showed in a different format, that, you know, some groups like Native American young people, you see the risk is really high and decreases rapidly at the end of the 20s or young adulthood. And you see a kind of also a less pronounced peak for some other racial and ethnic groups. And so, and a really steep peak for white individuals. And so how can we flatten that so that we don't see that steep peak and try to get young people off to the best start that we possibly can? The other thing that I think is important for everyone to be aware of is that in this shifting epidemiology, one very frightening finding that we're seeing in the field is that younger individuals are dying by suicide and making attempts. You know, second graders, third graders, and the field is really unprepared to address this new challenge. We've seen this nationally, we've seen this in Maryland, and so what can we do to better equip our providers, our healthcare providers, in primary care and emergency medicine, in mental health, and other areas to be able to respond in a way that's going to support the family and provide the services to that young person that they need. And part of the challenge is knowing, do individuals that young, 6, 7, 8, do they understand that suicide is final? Do they understand what it means? And these are all challenges to the field that federally, the NIMH as an agency is really working to address, and other agencies such as SAMHSA are thinking through ways to do this. But the one finding that I wanted to point out that really catalyzed this Ring the Alarm Crisis of Black Suicide in America report by the Congressional Black Caucus was this finding that prior to age 13, one thing that we see locally and nationally is the Black youth are much more likely to die. They're twofold more likely to die. And you can see they're at increased risk in this slide up until about age, dramatically at age 11, then decreasing at 12, and then it switches and white youth become at higher risk. And this is has been a challenge for our field and how best to address this. One thing we're doing in the state, thanks to Dr. Nestadt, is psych autopsies. So we are going to the families of these young people who are ages 13 and younger, and seeing if we, Paul and his team, including me, doing interviews with the families to learn from them about the risk factors and to learn from their experiences so that we can be better at prevention in the state for this, especially for this young age group and other high-risk groups in the state. We're doing the same approach of the psychological autopsies, learning from the family, but also giving the family an opportunity to get some support if need be. The other problem with the field is that we really need to take more of a systems-based approach. And one thing that we see in the field is that we for the most part, know what works. We know a lot of evidence-based practices work for suicide prevention. Unfortunately, many of them never reach the community. They never reach the mental health professionals in private practice who could benefit from learning DBT or CBT or other evidence-based treatments. A lot of prevention programs never reach the schools that they've been shown to be effective in, or college campuses, or juvenile justice settings and other settings. And so it is a real problem for the field. And I wanted to just point out, this is one of my favorite papers that I've ever read in my career. It's a really nicely done paper. And this paper is by Weil. It's a group in England. And what they did is they looked at mental health service recommendations. So these are recommendations for mental health services, mental health providers in the community. And there are these 9 evidence-based mental health recommendations that were put forward. And you can see them listed here. These are the 9. And what they were doing is they were looking before they were, communities were recommended to follow these 9, and then kind of during and, kind of during post. So the rolling out of, okay, these are the service recommendations. Everyone should be doing these. So they made the recommendation, and then they looked to see which clinics were implementing these and how many they were implementing. And so these are based on a lot of literature and clinical evidence. And so what they found is that the services that had implemented 7 to 9 recommendations had a significantly lower suicide rate than those implementing fewer. So there's this powerful impact of this comprehensive approach. Let's roll out as many as we can, get these evidence-based approaches out there, and they do make a difference. Here you see the suicide death rate was 17% lower among those that implemented a more comprehensive approach. And the interesting thing was they looked at the 9 specific recommendations to see which ones were the most potent or most effective. And what they found is that having a 24-hour crisis team, these are teams that are available to go out into the community and rapidly respond to a crisis, that was one of the most effective elements. Also having a protocol for how to manage patients with dual diagnosis. So these are individuals with substance abuse and co-occurring mental health conditions. So having a strategic management approach for patients that meet that criteria. And you can think now in the pandemic, with the rates of alcohol and substance misuse higher than we've seen, that this may be this type of approach may be especially influential right now, is also with the 24-hour crisis team. And then the last one is another fascinating one, and it reminds me a little bit of the strategy that we're going to be employing with Paul Nestadt, the multidisciplinary review. And in this project, what that was it was kind of like an after-action report. When a service lost a patient to suicide, what they did is they met as a team. Everyone came together. They reviewed the records. They talked a lot about, okay, what could we have done differently? Thought strategically, like, okay, moving forward, let's revamp our strategy. And what they also did is they reached out to the family and they engaged the family. And that recommendation was also one of the most influential in this paper in terms of the impact, like employing this multidisciplinary team that reviewed the records, that spoke with the family, that reached out to support the family, had a profound impact on these providers and could potentially have changed their practice. Another really important and innovation that we could be thinking about as during the pandemic and even before, there's such a need to think about the limited resources that we have for suicide prevention, the limited dollars that we have, and how to use them most effectively. And that is, it's such an important thing because we have so few dollars and so few resources and so few people. We want to make sure that we maximize the dollars we have to help the most people and to save the most lives. So this paper that I'm going to talk about right now really didn't get a lot of attention, but I thought it was really important. This one is from 2018, and it was by the former one that I just showed you was by a group in England, and this one is by a group in Australia. And both of these countries have been able to build more momentum and make more impact than we have to some extent in the United States. And so they're good models for us to look at in terms of what people are doing right. So this group, what they did is they got a bunch of stakeholders, people with lived experience, providers, all people from different backgrounds interested in suicide prevention, got them together. Okay, let's go over the evidence-based practices. Let's look at our population. So what does our population look like in terms of demographics and clinical factors? And let's use our data and the evidence-based practices and figure out applying these. If we were to take these specific intervention approaches and apply them to our community, which are going to be the most impactful and effective types of programs for your demographic and for your population of interest. And they did this in Western Sydney, Australia. So they carefully reviewed all the literature and publications and randomized trials, and they spoke to clinicians who gave them a lot of information on the most effective programs. And then they did this this type of modeling approach where they projected out over 10 years in the future, if they implemented these programs in combinations, which combination of programs is going to reduce the suicide rate and reduce suicide attempts the most. It's I think a very clever thing to do. And so here you can see when they looked at their data, one thing that they found is post-suicide attempt assertiveness aftercare. So that is like if somebody makes a suicide attempt, they're hospitalized, and once they go back to their community and their home, they do some proactive following up, supporting the individual, making sure they have the resources and support they need, trying to connect them with the community-based services. And they found a 6% reduction in suicide attempt as well as suicide. By deploying that approach across Western Sydney, they could achieve that result. And then they looked at improved community support and reduction in psychological distress in the community. So this was kind of a murky area. It wasn't very clear what they were thinking with this approach, but they showed by deploying this type of providing support, trying to identify folks with psychological distress in the community and get them hooked up with the care they need, they could reduce suicide attempts by 5% and suicide by 16%. And then re-engaging those lost to follow-up. So folks who went into an initial appointment and were lost to follow-up just didn't come back. And really trying to re-engage those individuals for whatever barriers or whatever access issues they had, try to re-engage them. And they found a 10% reduction in ideation and in attempt and suicide by implementing or rolling out that type of approach. But interestingly, when they looked at the combined impact, so of those three plus increased staff training and community infrastructure, that can result in the largest number of suicide attempts and suicides averted. And they say by like 30% of attempts and about 37% of suicides. And so that they're using their data and they're using this modeling to figure out what the best set of interventions will be. And this is important for a number of reasons, for strategic planning, but also to guide the prioritization of services and interventions and policies for a given population. And so this type of approach is something I've been wanting to implement in Maryland and thinking about our population here and the strategies that would most be culturally and appropriate for us, and thinking about making this type of data-driven decision making. And we do have a strategic plan, and so maybe even testing out the components of our suicide strategic plan in this type of a way. And they had this fancy modeling that they did where they could look at baseline of what their suicide attempt and their suicide rate looked like, and then by deploying these approaches, what they could achieve in terms of the benefits. The longer I've been in this field of suicide prevention, the more I realize that we have to be better at engaging policymakers and thinking strategically about working with NAMI and other groups who are also engaged with legislation and policy, and in ways to improve legislation and policy for those with mental health conditions. And so some approaches that I think are essential in order to move forward is improving access to affordable and effective mental health care. There's a real promise with COVID, in this COVID pandemic, about telemental health and improving access to people in more remote geographic areas and other challenges to maybe mental health services by tele is more accessible for them than other approaches. And of course, the promise of potential mental health apps, which is another form of technology that we're hoping will be fruitful for those in the future who may not be engaged in traditional mental health services, or if they're engaged in traditional mental health services, perhaps the apps can augment the treatment that they're getting, but also strengthening the chain of care for individuals. One thing that I would love to see happen soon would be this idea of, NAMI's fantastic at peer support models, and thinking about how can we more broadly deploy peer support models and peer navigators, family navigators, and having those personnel in our healthcare system working with youth and being able to help connect the dots for those individuals who have different barriers to access to care. Integrating primary care in community mental health is another form of strengthening the chain of care for suicidal individuals. Paul went over reducing access to lethal means, and because over 50% of those nationally who die by suicide use a firearm, it is essential that we think about all the recommendations that Paul made earlier, and how we can use them in our everyday lives when we recognize somebody at risk? How do we have a conversation with somebody? You know, are you comfortable asking somebody if you know that they or their child is at risk for suicide? Are you comfortable saying, do you have a firearm in your home? Is that accessible? And having that type of a conversation with somebody could really make a big difference. Embedding evidence-based approaches in educational programs, because of the lack of uptake of a lot of evidence-based approaches, this idea of thinking about ways to train teachers on how to do the good behavior game and other evidence-based approaches, or training physicians in training on evidence-based practices, journalists, training them on making sure they know about safe reporting on suicide, and can we embed that in journalism schools? And how do we embed these evidence-based approaches just so they're part of people's job? You know, so they don't have to get this in the future. It's just, you know, when they're trained, they just learn all this material and, you know, potentially have continuing medical education later, or continuing education to enhance their skills in the future and update them. But the part of the problem is, you know, you saw it with my presentation and Paul's, is that the data we have is already old. And we really, in order to learn about the pandemic and its impacts, it would be great to have finalized data in our hands now to be able to use for action. And with the lags in data, it's hard to be able to do that and think strategically about suicide prevention in a data-informed way. And just to talk I know I'm almost out of time here, but just to talk a little bit about opportunities to leverage policy. And the American Foundation for Suicide Prevention has this great document that goes over in every state what types of policies are available and in place for suicide prevention. And in Maryland, we have the state mandated annual training for school personnel. So can we use that policy in order to implement programming that could really make a difference in our state? And how can we leverage that policy for suicide prevention? And so that's one thing we're thinking about. Sometimes these policies are in place and people just take what's easy or may not be the most effective approach, but how can we really give them, you know, school personnel, teachers, and school mental health professionals really high impact training that can really change the way they recognize those at risk and respond to them. So this is one thing that we're really thinking about. And schools are an ideal place from a public health standpoint because of their naturalistic setting. They're a place to reach people without the fear of potentially of stigma. We can identify students early when they're in the building. We can provide prevention programming and different mental health resources. And we can support individuals in the aftermath of suicide. And so schools serve such a critical role in engaging young people in prevention. And educational policies in the United States, even more now with the pandemic, are increasingly calling for the expansion of school-based mental health efforts. And many of you probably know that with the pandemic relief funds that we have in the state of Maryland, we are going to be deploying regional mental health teams that will help support and enhance the services that are currently available in schools. And so Maryland and many other states are using the federal pandemic relief funds to enhance mental health supports, recognizing that students have been out of school for a long time. Youth at home were absorbing lots of stress. They were isolated. They were missing opportunities. Their routine was changed. And school provides a lot of support for many students, and that was shifted over the course of the pandemic. So there's great promise, I think, with these mental health teams and family navigators will be part of these teams that will be rolled out. The role that these programs that build skills that are in schools can play is not only can they teach kids skills and how to recognize those at risk and when there's a crisis what to do, but they also can demystify and destigmatize mental health treatment. And in a recent review of the state of the science of suicide prevention, John Mann and his team, this is about 10 years ago, they published a review, and there's some new things that are in this updated review that was just published. And one of the new things is that he found that programs that were directed at youth in schools, like teen mental health first aid, or programs that students were taught directly rather than teaching only the faculty in the building or the adults, but programs directed at youth reduce suicide attempts. And so that he pooled the studies in this area, and there were enough now in the field to show this impact. And so that's one area that we're really focusing on. I'll just stop there and thank you very much for your time.
Oh, wow. Thank you. Thank you. Thank you, Lieutenant Governor Boyd Rutherford, Paul Nestadt, and Holly Wilcox. Paul and Holly, thank you for providing this critical information during this great time of need. We would like to open up the webinar now for any questions that you may have. Remember that every participant will stay muted to avoid background noise, but you can type your question into the question box at the right-hand side of the screen if viewing from your computer, or at the bottom of the screen if viewing from your phone. If you have a question that you would like to ask, or if you have a comment about the webinar today, please enter these into the questions box now. If we do not have time to answer each question today, we will provide our contact information at the end of the webinar for anyone who may wish to reach us. First question, with addictions rates going up, how has the suicide risk been impacted? What can families do to help a person with comorbidity present?
Paul, do you want to take that one?
Yeah, sure. Sorry, I was moving my go-to webinar video windows. So you're saying, so how is the question? How can I help someone impacted by psychiatric illness? Is it risk for suicide?
So what can families do to help a person with comorbidity present?
So there's a lot of different things to do, and it really depends on the situation. So in an acute crisis, if someone is at risk of suicide and maybe having suicidal thoughts, or you believe things have gotten much worse, they're isolating, they're in a dangerous position that in the past has led to suicide attempts. Those are times when you take extreme measures. That might be, not just sort of talking to the person, but actually beyond that, if they're not going into care, calling the BCRI crisis line or calling 911, even getting them into the hospital to be evaluated psychiatrically. So that's the extreme situation. But more commonly, one of the best things you can do if you think someone is starting to suffer, someone that has a comorbidity, let's say depression or schizophrenia, is talk to them, is get a sense of where they're at, and if they've been seeing their provider, if they've been having trouble getting a provider, that kind of thing, and doing whatever you can to help reduce the barriers to that care. So you might find out that one of the reasons they're doing so poorly is that they haven't been able to get to their, let's say, psychiatrist because of the pandemic, and it's been they've gone all Zoom, and that person doesn't have access to a webcam or Zoom. And that's the kind of thing that's actually an easily solvable problem. You can maybe help them with showing them how to use their smartphone. Some people have smartphones now, so that kind of thing. There's a whole range of things, and it's really specific. When someone's at crisis, though, as I said in my talk, one of the most important things during a crisis is make sure they don't have access to lethal means, so that if that suicidal thought does really start to spike and to peak into crisis mode, that there's not readily access to something dangerous like lethal medication or firearms, that kind of thing. So it's a range of supports.
Thank you. Next question. How can we help those loved ones that demonstrate clear signs of suicidal behaviors, but still adamantly believe that they are not worthy enough to receive intense mental health help that they need and do deserve?
So that's a very similar question. So really, a lot of what this comes down to is doing your best to convince someone to seek help themselves. But in this question, we have a scenario where someone is not willing to do that, and it sounds like because they don't believe they deserve it. which can happen. So, generally what people do is they do their best to try to convince them they deserve it, but in some cases, if you really feel like someone's at a crisis, that things have gotten so bad that they're at risk of hurting themselves, and they don't feel like they are able to or willing to get help, that's when you sort of take these more extreme tactics. That might be if there's a gun extreme risk protection order filing, as I mentioned, but more commonly something like an emergency petition, where you can file with the judge to have someone taken, even if they're not willing to, taken involuntarily to an emergency room for a psychiatric evaluation, where they'll decide if the risk is so great that that person might even need to come to the hospital. But so you have that option. Again, these are extreme situations, and people do better when it's a voluntary treatment, without a doubt. But in extreme situations, yeah, this sort of risk warrants extreme measures.
All right, thank you. How has the pandemic impacted suicidality?
Holly, do you want, or should I?
Well, I'll jump in first, and then Paul, Paul has a lot of the data and has been looking carefully at all the data. But, Paul and I both sit on our state suicide surveillance group. And so we're looking at the data with folks from the medical examiner's office and all different people from different settings. And, from my perspective, things have really changed a lot. Like the lieutenant governor earlier said, at the end phase of the tail of the pandemic, there's different, impacts on different people. And we've seen shifting over time in the groups that have been at higher, have suffered more suicides than other groups. And so it's changing, and it's hard to get a good picture. And also the data are not finalized, at least it takes a while to finalize and conclude, have a conclusive cause of death. And so that takes a while too. Paul, do you want to jump in?
Yeah. So, as Lieutenant Governor Rutherford mentioned, we're expecting the tail end of the pandemic to be a mental health. So what we've seen so far, I mentioned in my talk, we were expecting a perfect storm. We did see dramatic increases in suicidality, which I'll use that word to mean people reporting suicidal thoughts. Crisis line calls in Maryland and nationally. In Maryland, they tripled. Really just dramatic. ER visits for suicidal thoughts and a suicide attempt, especially in pediatric settings, increased in most months of the pandemic. But interestingly, and the data is not final, suicide deaths did not. So far, what we've seen in 2020, what we did see in 2020 was suicide deaths actually went down in aggregate. Although I have a paper looking at Maryland suicides that noted that that was driven by a decrease in white suicide. White suicide rates went down relative to recent years. Black suicide rates went up. In fact, during our first lockdown period, where we have good data, Black suicide rates doubled compared to previous years, historic norms. Really worrisome. Maybe because the pandemic impacted Black Marylanders more. We know the case fatality rate was higher, the infection rate was higher, more likely to be on the front lines. That could be something to do with it. But there's this weird thing where in aggregate, suicide rates have gone down in Maryland and also every local jurisdiction where we see 2020 data. But where it's been disaggregated by race, it's been people of color, Black, but also Latinx community, where it's gone up. Now, there's also a lot of evidence that will be coming out that youth suicide has specifically been increasing. And I don't think we can talk about that yet, but just to say that that's an area in Maryland that we're specifically worried about in that tail end of the pandemic, where the mental health shoe might not have dropped yet. We might still be in this sort of, still in crisis mode, still in adrenaline mode, still in heroics mode. And people, as the pandemic starts to get better, hopefully, and it goes away, we're still left with people that don't have jobs, that are in debt, businesses are closed, people are dead, and there's mourning. So that's what I'm worried about. That's the bottom.
Thank you. We have time for a few more questions. Paul, you talked a lot about the data. We have a question. It says, how do we address the data lag at the state level?
The state's pretty good. So my biggest concern is the federal data lag. The CDC they want their data to be very clean. So they take all the different states and they check it and double check it, make sure it's really good. But it does take time. So we won't see federal data for 2020 until probably December. At the state level, not to get into nuts and bolts, but basically the medical examiner's office in Maryland. We've got a statewide medical examiner, which is fantastic. Most states don't, who gets all the decedent data, including manner of death, meaning suicide versus homicide or accidental overdose, that kind of thing, and consolidates them and and make sure that all of the investigations are complete before sending it on to the state, who then double checks it and makes sure that it's all solid data and there's not errors, people from out of state that died in the state, that kind of thing. Or overdoses can be really hard to figure out the intention. Someone finds an overdose, it could be a suicide, it might have been an accident, it takes investigation, so that takes time. So if we were to rush state data, we end up with data that is incomplete, which might not be totally accurate. There's trade-offs. I like to see the data soon. I look at that data when it's raw, but I'm wary of publishing it until there's been at least 3 or 4 months after any given death cutoff. So I don't know that there's an easy answer, because it really does take lots of data processing and manpower. And the medical examiner does the best they can with very few resources. It's amazing what they do with like very little money compared to other states. But yeah, it's a good question.
Yeah, great questions. We have time for one more. I'm having trouble finding a mental health care provider with Medicare insurance. For those on Medicare, how do we find covered mental health providers?
I mean, I wish I had an easy answer for that. So it's tough. And I can tell you, one of my clinics is I do consultation psychiatry. So I'm seeing someone and then referring them to another psychiatrist to do the work that I've recommended. And it's tough even for me, who's connected to the psychiatric community on the board of Maryland Psychiatric Society. It's tough. Some things that might help sometimes. Talking to your physical health provider, your primary care doctor, they'll sometimes know people. And if they make the call, it might be easier to get in to be seen. There's websites like Psychology Today. Their website will list people by what insurance they take, and you can see where they are in your area. You can see a little brief description of that person too, someone you feel like might connect to. You see a photo, which honestly is helpful to people to say, oh, I can talk to that person. So Psychology Today, these aren't great. And then in general, for anything for insurance, especially public insurance, looking at big hospital systems. So here I'm in Baltimore, so I recommend going to Johns Hopkins, the community psychiatry program at the downtown campus and at Bayview campus. There's also Harbor Hospital has a fantastic one that is relatively new in Baltimore. I know this is statewide, but I don't know the rest of the state as well. But generally, major hospital systems are going to take public insurance, and they might have affiliate psychiatrists and therapists. Also ones that have residency programs, resident psychiatrists, which are psychiatrists who are doctors, but still getting extra specialty training, are fantastic. The studies show that they're as good, if not better, than experienced psychiatrists. So those are some options that are out there.
Nice, thank you. Thank you everyone for joining us. This webinar has been recorded and will be emailed to registrants tomorrow. The webinar will also be uploaded to our website at www.namimaryland.org for any individuals who were unable to register for today's webinar. We hope that this webinar has been helpful for you this afternoon. At the end of the webinar today, you'll be asked to complete a short survey on the aspects of this webinar that you felt were helpful, could be improved, and what you would like to see in future webinars. We plan to continue hosting educational webinars, and this survey will help determine how NAMI Maryland can best support you during this time. By being an attendee of today's webinar, you are also invited to join us for our virtual 39th annual conference, which will take place online on October 15th and October 16th, 2021. This virtual event will feature up to 40 workshops and plenary presentations over 2 days, covering important, relevant topics. Here's your chance to learn about the latest research, discover resources, develop a talent for advocacy, and foster a better understanding of issues relating to mental illness. We are offering all webinar attendees a heavy discount for the conference. Rather than the full 2-day price of $165, your price is only $50 for 1 day or $95 for both days. Simply click the link in the chat and use the promo code WebFry for Friday only, WebSat for Saturday only, and WebChew for both days in the discount code box. Make sure to click validate to get up to $70 off the total ticket price. That's right, $70 off. If you have any questions or if you have a problem registering, please don't hesitate to contact us at the email providered@namimarylandmd.org. We wish you all a safe and healthy rest of the week, and please do not hesitate to reach out to us through our website or by phone at 410-884-8691 should you need additional resources or support. Thank you and have a great rest of your day.
Sure.